All right, everybody. It's just afternoon here in Baltimore. So, welcome to this calendar year's first seminar of the Johns Hopkins Center for Clinical Trials and Evidence Synthesis. My name is Ian Saldana, and I'm an associate professor of epidemiology here at the school. And our speaker today, and we are very glad to have Dr. Brett Thombs, who's a professor of psychiatry at McGill University and a senior investigator at the Lady Davis Institute for Medical Research, which is at the Jewish General Hospital in Montreal, in Canada. Dr. Toombs got his PhD in clinical psychology from Fordham University in New York, after which he did a stint at Johns Hopkins here. He was a fellow and then an instructor in the School of Medicine. He then moved to McGill University in 2006, so 20 years ago now. His main interest areas, research interest areas, are quite diverse, but they're very relevant to the interests of those in our center working on different topics and students in our center as well. He's published widely on these issues, primarily in three areas. That's evaluation of interventions for people with rare autoimmune diseases, on meta-research, in other words, how the design, conduct, and reporting of medical research may itself lead to biases. And then what he'd be largely focused on today, depression screening and the evaluation of depression screening tools. So in 2020, Dr. Toombs was named a Canada Research Chair. And among his other accolades, he chairs the Canadian Task Force on Preventive Health. He directs the Scleroderma Patient-Centered Intervention Network, or SPIN. And he directs the project we'll be talking about today, the Depression Screening Data, or the DEPRESSed project. So the title of his talk is Individual Participant Data Meta-Analysis to Address Gaps in Evidence on Depression Screening Tool Accuracy. Very glad you're doing this with us, Dr. Toombs. Welcome, and over to you.
Great. Thanks, Ian, so much for the invitation, for being here. So I'll talk today a little bit about why it is we're doing individual participant data meta-analysis to address the problems we hope we can address with it. What is an IPD, individual participant data, IPD meta-analysis, some advantages and disadvantages, and how we've used this framework to address the questions we want to answer. So just a very quick disclosure: all of the funds for our group is public funding, so no conflicts of interest to disclose. And my interest in depression screening actually started at Johns Hopkins. So I came to Hopkins wanting to be a clinical psychologist, and realized late in my doctoral training I had to do a postdoctoral fellow to get licensed. So I showed up at Johns Hopkins, doing clinical and research, and then the Hopkins magic hit me, and it really is this wonderful environment where there's wonderful people, smart people, research going around addressing real problems. And so before you know it, I actually was doing research and thought I liked it, and that's where I planted the roots of doing the research that's led to what I do today, or with the team. One of the things I was doing, and I came across paths with Roy Ziegelstein, who some of you might know, who's a cardiologist at Hopkins, and until recently was a vice dean of education. And as I started working with Roy as a fellow, and who unofficially became my mentor and still is today, I was interested in assessment in depression, and doing some primary study work and calibrating assessments. And Roy touched base at that point with Michael Lauer at JAMA, who is head of their cardiology section. And Dr. Lauer said, why don't you everyone's interested in screening, why don't you do a systematic review and see how, if screening is effective in cardiovascular care. And so I thought, oh, that's okay, we'll do that. So Roy and I put this together, and we looked at the evidence at that point, and essentially we didn't find any trials on depression screening and cardiovascular care. We found that there was little evidence on accuracy of screening tools, and like everywhere else, depression screening effects and treatment are pretty small, but important if you have depression, but small. And it just turns out that, unbeknownst to us, the same month, the American Heart Association put out to great fanfare scientific recommendation for screening, and they encourage everyone to screen heart patients for depression. And my first or second year here at McGill, a young faculty member, and everything went kind of haywire because people weren't very happy with us that we suggested there wasn't evidence for what they just recommended. And you can imagine where things went from there. But there's quite a bit of controversy around this. And so, I thought, well, let's what got more into what does it mean to look at for depression screening? What kind of evidence we want to have? Before we go down that route, though, what is depression screening? Essentially, it's a little different from most the traditional screening paradigm is that we use tests to find things we couldn't find otherwise, whether it be, a mammography, breast cancer screening, PSA screening for prostate cancer, whatever it may be, right? Infectious disease screening. But you're looking for something that's asymptomatic. You're trying to find it upstream before it presents itself. And then that theory is that if you find upstream far enough, you can ward off some of the negative effects of it. And of course, it's very difficult to do. We have a handful of things that we typically screen for, and most of the things that have been attempted haven't worked. I mean, it's a big, long pathway, right, from detecting something to getting people into treatment to treating it effectively in a way that you could better than what you could do without the screen, and with enough benefit to justify it and so forth. So for depression screening, the model is that you answer these questions. This is the patient health questionnaire 9, which is the most commonly used tool now. You come with a score. You have a threshold. If you're above the threshold, if you're not above the threshold, you don't get assessed. That's the end of the day. If you are above the threshold, you get assessed by somebody. So somebody who's capable of doing a mental health interview should assess you. Then you're either diagnosed or not. And if you are, you may talk about whether it makes sense to get into treatment. That's the basic paradigm. And then we said we didn't find any trials. And this is one screening. Sometimes screening endeavors are very difficult to test. You might think about things like Hep C screening through a trial and how many years out you'd have to find the outcomes. But depression screening is definitely a doable trial. There are some trials. But you basically randomize centers or in clusters to screening or not screening. And if people are not screened, they can get detected for depression even before anyone was talking about screening. 10, 12, 13, 14% of North Americans were on antidepressants as it was. So people are getting treatment. So you can get treatment that way. Either tell your healthcare provider you're concerned about your mental health, they detect something they want to ask about, or alternatively, you could screen people, in which case, if your test determines whether you're going to have that diagnostic interview and so forth, and a potential offer of care. And again, this is the British are always very good at these things. And John Muir Gray, said all screening. This is a classic quote. All screening programs do good. Some do good as well. Do harm. Sorry, some do good as well. And some of these do it at more good than harm at a reasonable cost. So this is kind of what the paradigm is. Like, is there benefit to start from screening? Not just can you detect more people. You always detect more people. Can you actually detect them and change their health in a positive way beyond what you could do without screening? And of course, you have to weigh that against the harms that you'll cause. And this is the classic, case in, say, breast cancer or prostate, how much harm you're doing. And people know those. So, any screening program. And is it reasonable to cost? And that's actually, the cost is much more on our map, perhaps sometimes than it always is in the US because of the different systems. And we are a single payer system. So it's quite little. In our system, if you're doing this, what are you not doing usually? So just a quick fact. So again, we conclude at the time that there wasn't evidence of screening in heart disease, that there weren't any trials, and there's some reason to think it might not work. So there needed to be trials. Just a quick fast forward. This is not something we've published, but this kind of got away from us during COVID. But we did start to look at whether the whole screening paradigm was screening with a questionnaire for something somebody already knows they have, right? Rather than telling you screen them. And we started looking at many different areas where people could screen with questionnaires in a clinical setting. You'll see what they've listed here. And this is very rough what we found, but you'll see that out of all these outcomes, there are something like 225 null outcomes, 3 positive outcomes, and it's really not 30 outcomes favoring non-screening. That's because one study measured pain in like 25 different ways. So, but it's, you have 220 some null outcomes, a tiny number of positive and negative outcomes on either side of the null. And out of these trials, to be fair, there's probably only 3 or 4 or 5 strong trials, or a couple in intimate partner violence that are really well done. There's a couple in depression that Ian Cronish's NIH-funded trial in heart disease, actually, and a couple of others that are pretty solid trials. And just to put this in perspective, and then we look at recommenders. These are the national screening recommenders, the Canadians, the British, and the American task force. So you'll see that what's going on in the US is unique because this just lists all the different things we looked at in terms of questionnaires that you could screen with. And you'll see that either in the Canadian or the British scenarios, we've either not evaluated it or we've evaluated and said that it does not evidence to do it, where the US task force often does recommend it. But that's kind of where we are with this. Um, so how do you evaluate at screening tests? Because one thing that, is when I was younger and thought about, continue to think is that, you know, it's not a given that depression screening or any other questionnaire-based screening can work. But if we're going to do this, we need to have a better handle on how we measure these things and how to set a cutoff and how accurate the screening test would be at different cutoffs. And so just for a basic, I know Ian said there's students on the call. Some of you'll know this quite well. But the way we evaluate tests is pretty standard. Their accuracy to start with. And again, on the right, you'll see there's different cutoff thresholds, and every cutoff threshold has different properties to it. But the way we do this, we look at sensitivity and specificity to start. For analytical reasons, sensitivity is just if you have the condition, in this case, depression, how likely are we to find you with this test? If you don't have it, if you're in a negative case, how likely are we to correctly rule you out? Specificity. And we look at those, but I mean, there's some nuance to these assumptions, but we do assume that those are transportable across populations and so forth. What really people want to know in a clinical setting is if I give you the test and it's positive, how likely are you to have a positive test, meaning you have the condition? That's the positive predictive value. And versus the negative, right? How likely are you really to be a true negative if we find the test calls you a negative? Those depend on your prevalence in the population. And again, these are very rough assumptions here, but that depends on that. But you can easily calculate those once you understand the sensitivity and specificity. So this is the basic model. It's a 2x2 table. You either have a case of a disorder or not, and you're either screen positive or not. So this is what we're beginning to look at. So, a few years passed from our initial paper on depression screening, and I think Roy and I wrote a few things about it. Others wrote some things and disagreed with us. And Brooke Levis, who did a ton of the work, along with Cheryl Sun, who's here on the call, is now a doctoral student with Ian at Johns Hopkins on building this program. But Brooke was a master's student and came into my office. And this meta-analysis actually started our DEPRESS project, or the Depression Screening Data Project. So this came out in 2012 as Simon Gilbody's group from the UK. He's a very good scientist. And they meta-analyzed the patient health questionnaire, and they looked across possible cutoff thresholds, the sensitivity and specificity, and they came up with this table. And this is your basic table. There's other things that go into it with forest plots and heterogeneity and so forth that are quite important. But this is their basic results table. And there's a real problem here. I wonder if I can ask people on the call, the students on the call, did anyone see what that might be?
Sure, yeah.
Okay, because if you look at this table, there's something that tells you this is a real problem. This is impossible. And does anyone, Cheryl, you're not allowed to answer this question because you've probably heard this like 85 times. Anyone else see what's wrong with this table? That alerts us we have a real problem with what's out there? I don't know, I can't see any chat or anything, so I don't know if anyone has any.
I'm not seeing anyone type anything
Okay.
yet. Feel free to unmute yourself if you want to respond.
I'm going to guess that the sensitivity goes down at higher cutoff scores.
Well, the sensitivity is supposed to go down at higher cutoffs, right?
Well, obviously. All right, then my guess was wrong.
No, but okay. Well, but you can think about it. If you think about sensitivity, right? The higher you raise a threshold, the fewer people you find, right? But the more, yes. So the higher a bar you raise for detecting a case, the fewer you'll find, but you'll more properly rule out people. So the higher the threshold, sensitivity gets lower, specificity gets higher. They play on each other, right? They go back and forth mathematically. Okay, but we'll build on that. So it's actually that the problem is related to sensitivity.
Brett, there are a couple of responses in the chat that that are basically getting at wide variation in the cutoffs.
What do you mean by the number of cutoffs that were examined, or what do they mean by wide variation in the cutoffs?
I think what they mean is different cutoff scores used across the studies.
Right. Yeah. So you'll see here that there's you know, um, yeah, so there are 5 studies reported cut off 7. Most of them reported cut off 10, which someone is the first study out there, which had about 50 cases or something that was standard. So it's become our standard. They mostly report that, but then there's wide variation. But that isn't necessarily a problem necessarily. But if you look here, the problem is that again, as you raise the bar higher, um, okay, now I can't actually see the chat. Number studies don't add up to 18, right? That's true. So the different cutoff scores. Yeah, that's all true. But if you look here, why we have a red flag, again, as you raise the bar higher, fewer people are going to get over it. And if you see here the sensitivity actually goes up. As you raise the bar higher, the cutoff score higher cutoff score means you need more depression to get over it. And between 9 and 11, sensitivity gets better from 83 to 89. Goes down, then it pops up again. So this is mathematically impossible. If you have a group of people and you raise the bar up, it actually the sensitivity has to stay the same if there's nobody in that cutoff range, or it has to get worse because you're finding fewer people as you raise the cutoff above their scores. Okay, so this alerted us that we had a problem here, and you'll see the specificity seems to behave about as you think it should, right? It stays the same or it goes up. It goes up as the threshold gets higher. So Brooke, as her master's project, decided she was going to actually go back to these studies and see if they would give us their data. So we had the idea that we should be looking at this because the problem here, as some people pointed out, is that not everybody reported the same cutoff. So we want to have all the cutoffs for all the participants to analyze, and that was a problem here. So Brooke did a really beautiful job with this, and not only she go out and got data from I think 13 studies out of the 18 here, but what she did then, she took those 13 studies and she looked at what they'd published, only using the published cutoffs, and then she took all the data because now we had actual individual participant data for each participant in their studies. For all the cutoffs. And you'll see for people who know these are ROC curves, sensitivities on the y-axis, 1 minus specificity is on the x-axis. So they should go up in a nice curve as you see the check on the right here. Whereas sensitivity gets higher, specificity or 1 minus specificity also gets higher. And you'll see what here on the left, which is what they actually published, was kind of a jumble. It didn't make a lot of sense. So what Brooke also did in figuring out how this works, and she looked at what people were saying their optimal cutoff was. Now, this is a whole nother ball of wax. If people take their optimal cutoff, they almost always balance or maximize the combined sensitivity and specificity. Now, if you're going to screen in practice, that's not necessarily the way you go about it. There's no reason why you'd want to balance sensitivity and specificity, but that's what they do in this area. So we said, okay, let's come up to do what they're doing. And if you look at the O's on this chart, these all the studies down the left-hand column here, and the O's are where they found the optimal cutoff. And now you'll see that people whose optimal cutoffs were lower than what people think is the standard, including a study I did in 2008. So I did this very badly myself. You learn as you go along. You report thresholds that are below the standard because that's where around your cutoff you found. If you're higher, you report around that. Now, if you think about this for a second, though, if you're trying to maximize sensitivity and specificity, and you have to go down to a 5 or a 6, that means your test is not very sensitive in your population. You've got to drop that threshold to catch people. On the other hand, if you're moving it up to 12, 13, compared to the norm, or your test is highly sensitive. You can move it up even higher, still catch your cases, right? The sensitivity, and kind of maximize the specificity around it. So you'd think you'd have some different characteristics here, right? Low sensitivity tests report below the standard, high sensitivity tests report above it. And this is what Brooke found here. It's very, very elegantly done. So I think so. What she has here, she has each cutoff. She has, what were included, a percent of the total cases. So the total cases were the ones we had individual participant data for. She reported there the percent of total patients and cases that were included in the published results. And then and cases are really important here when you're looking at test accuracy, because you think about, you analyze sensitivity and specificity. Sensitivity is driven by cases. So keep that in mind. If you have 200 people, but 5 cases, your N is 5 for looking at sensitivity. So your results are driven by how many cases. So the total participants doesn't matter so much. It's how many cases you have. And you'll see that, so 53% of the cases were published. So down here, about almost half of the patients and cases were in the publications, around 10, most of them, and it's very low up here. But you'll see, if I remember from the previous slide, the studies that were publishing below the 10 were low sensitivity. So they underestimated, the published results underestimated true sensitivity quite substantially. The ones that were sensitive were overestimating sensitivities quite substantially at these cutoffs. So, so the published data underestimates at the low end, overestimates at the high end, and it kind of flattens that sensitivity curve and it really kind of makes it look like all the cutoffs work pretty well, no matter what you're doing. And you'll see that one thing she found here is that, though, that and specificity didn't matter. So you have small numbers of cases, and those are driving this. You can move the threshold around to get cases and not affect this very much. And we subsequently replicated this. Deepika Nupane did this with more PHQ studies in the future and some EPDS studies, which use in postpartum. And so the other things we were noticing, and this is related to the previous slide, is that many studies use very small samples. The median number of participants is fewer than 200. The median number of cases is fewer than 30, which again, that's your N. And what was typical, these are just some examples here, but it was typical is like, in diabetes patients, you should use an 8 instead of a 10. In Chinese patients, you should use a 7 or more rather than a 10 or more. And we thought there was a good possibility that this was just due to sampling variation. That there might not be, there could be specificity related, for different populations that it might matter. But we didn't think anybody had shown that because this we thought was probably related to imprecision of the studies. And then the second one we noticed is the issue we found is that you have to have a gold or reference standard here, and that means that what are you comparing it against? So in cancer screening, there often be, some kind of tumor board or evaluation is the outcome to verify that, they actually did or didn't have. And this again, not straightforward all the time, but did they actually have the condition you're looking for? So in mental health, we use interviews. So rather than a questionnaire where someone just checks off a series of questions, we actually have an interview. And there's several kinds of interviews. The one that most closely replicates an actual clinical process is a semi-structured diagnostic interview. That means that all the researchers who do this go through the same steps and the same framework to interview the study participants, but there are places when they can query. If things are unclear, they can ask some questions, they can logically follow up and make a judgment as to whether the condition is present or not. These are expensive because you really have to be able to diagnose on your own without this structure to be able to do it properly. So you can imagine you need a clinical social worker, a clinical psychologist, a psychiatrist, usually to do that. So what happened way back is, I think the WHO was one of the leaders in doing this, World Health Organization. They came up with something called the CD. I'm very bad. I don't know what these acronyms all stand for. It's I won't even try it. The CD is the interviews, but they're fully structured them. So what they did is that they now these were fully scripted. So there's no questioning. And you could have, trained lay researchers could administer these interviews. And it is, if you're absolutely doing these right, a patient might say, or participant might say, I'm not sure about this. This is my experience. How should I answer this question? And all you can really do is say, I'm sorry, I can read you the question, but you've got to decide. So there's no judgment here on the interviewer. It's a lot cheaper. And if you think about it, the idea is that since you completely scripted it, you're going to gain reliability because everyone's doing exactly the same, but you probably lose some validity because you can't make any judgments here with expertise. And there's also a third kind, which is a super brief, fully structured interview. One is called a mini interview, which is commonly used. And these don't go much beyond questionnaires, frankly. So they're done by a person, an interviewer, but they don't have some of the nuance. And some of the nuance, I mean, the probing on whether the symptoms are due to a health condition or substance use or some of the other nuances that go into actually making a classification for mental health. So we started, idea way back. We went out and got grant funding. We decided we're going to do individual participant data meta-analysis because we could use that to answer some of these questions. And this is where we are today. So thanks to Brooke did a ton of work. Cheryl did a massive amount in orchestrating how our methods and how we orchestrate this. But so now we have, it's all been Canadian Institutes of Health Research funded. We have over 500 data contributors from 60 countries. And we've looked at three measures, the Patient Health Questionnaire 9, the EPDS, which is done in perinatal care, the HADS, which is more done in Europe than North America. It's intended to be done in hospital settings. They don't ask questions about somatic symptoms. And we've begun to look at the geriatric depression scale. That's the one we're struggling a little bit to get as much data as we would like for it, but that's in progress. So, but this has allowed us to put together some big data sets. I mean, there's over 100,000 total participants. Sorry, I left off a zero there. Over 12,000 major depression cases. Like the PHQ data set, I think probably has 50 or 60,000 now participants, and over 8 or 9,000 cases, I believe. So how does this all relate to what a conventional meta-analysis might be? And I think people are familiar with that, or systematic review or meta-analysis. You might also call them an aggregate data meta-analysis. So usually when you're doing a systematic review, you're going to systematically find your eligible studies. People, I'm sure, at Hopkins, you guys are well schooled in this. And then you go out, make a decision whether you can put it together or not quantitatively. But what you're going to do is you're going to collect summary measures from investigators or published papers, right? So in this one, it's like the first meta-analysis in test accuracy I showed, where you actually only get the sensitivity and specificity for whatever they reported. This is the same in trials. They're going to report outcomes, and with some degree you can ask people for things they didn't report, but you can't do that carte blanche in everything. So it depends, it's an aggregate data. It depends what's reported in the studies, and you really limit it. You can't overcome some of those. So you might face some challenges like definitional differences, how they define cases, or outcome measurement thresholds, and so forth. So, and this is kind of a very rough flow of what you do. In a systematic review, you're going to go through title abstract screening. You're going to go through your full text screening and exclude. You're going to have some studies that meet the eligibility for criteria. You have additional studies identified. Sometimes you'll look at you'll query authors and so forth, which we do, and then you get this pool of eligible studies, and that's where our processes differ now. And this is a lot of effort and work, because once you have eligible studies, you've got to contact authors now and convince them that it's worth their while to provide their data. And so you lose some of that process. Some people don't have their data anymore. That's less and less the case. Some people don't have the resources. That's usually not the case. It doesn't take many resources to provide a data set, and we have a little bit of funding for that. Or some that don't wish to provide their data. And then you've got to get into data transfers, and this is not as easy as it sounds, because anytime you get lawyers involved with data transfer agreements, you've got a long process. And so, again, thanks to Cheryl and others who've done this, that it's a lot of work. So you have data transfer agreements, you bring them over, and then you've got to transform the data, because there are all sorts of different formats. So the team has to put them together into the same format. You have, a rule-based coding for how you handle different situations, how we put it into our codes. We don't have it on here, but we try to replicate what they publish, right? So if we can't replicate what they've published, we don't have confidence in the data. And we haven't gone here, but because it's probably not good for getting more data, but there are a fair number of studies where you can't replicate what they've done, unfortunately. And then we have to make a decision if we can work it out. If we work with the authors and say, we figure out what the discrepancy is or what the error was, then we're comfortable that we believe we have accurate data. We'll use it. If we can't work it out, then we don't use the data. And then you go forward with the meta-analyses. So again, in our standpoint, it combines that participant data rather than summary results, and gets us all the cutoffs for all the participants. It lets us do subgroup analysis. I don't know if any accuracy studies, given the small number of cases that I've seen that have tried to do subgroup analyses, and there may be one or two out there, but I haven't seen them. But we do subgroup analyses, so looking at accuracy by sex or gender, or other location groups, or medical condition, and so forth. We can also exclude people. We don't have to include everybody from the original study. So screening is done on people you don't know have depression already. So you have some studies where people enrolled through a psychiatry clinic and people enrolled through a general family medicine or general practice, we only take the general practice ones. We can then manipulate the data sets to only fit the ones who would actually be screened in practice. Now, just like mammography, it's an point to make. You can use a mammography for screening people. You can also use a mammography to follow up clinically, right? If someone's had treatment or whatever. So the same test, different purposes, but only the first one's screening. And that's why we same with mental health. You can use it as an outcome measure, like the PHQ, and monitor people, but it's only screening if you're going out to people who you don't know whether or not, you know, don't have any reason to think they might have it, and you test them. We standardize the inclusion, exclusion, variable definitions, and we'd like to move on to individualized depression risk estimates beyond this dichotomy we're talking about. But that's takes a lot of data, and we're still working on that. Disadvantage, as you probably picked up on by now, it's super time consuming, it's very expensive, and you have to be able to assume that the studies you exclude aren't so different than the ones you were able to get the data for. And we've tried to analyze the ones that don't provide data, and they don't look so different, but then again, I mentioned before, they don't always provide very many of the cutoffs we need. So it's a little bit tenuous to say that we're getting the same data. So far, these are our main meta-analyses. We've done the PHQ, all of these, and they're not that, I won't go into them other than the fact that this has allowed us to provide pretty good estimates of accuracy for all these tools. And a key finding actually is that we've never found any subgroup differences that were substantive enough to matter. So that maybe just a takeaway on that. But more interesting, and it's also allowed us to put tools online. So if you're people that are screening, again, it depends on your country, but in what jurisdiction. But so in the U.S. you are screening, and you want to pick up and use a tool and actually put in what you think your prevalence might be, and we have some guidance here. We have a set of tools that you can look at and say, okay, from a clinical standpoint, I have maybe 10% prevalence of my population, 5% I've already picked up on. If I use this cutoff threshold, out of my positive tests, how many of them will probably have depression and so forth, so they can really get a more clinically oriented framework. And I mentioned a few of the questions we had before about issues with how people are looking at depression screening and accuracy. So one area we did look at is in data-driven methods in small primary studies. And this is what I was talking about before when you say we have different cutoffs for each country or medical condition. And this is just repeating this, use different cutoffs in these situations. So what Brooke did is to simulate this. So, we have a PHQ data set, and I don't remember the exact numbers. There's 50 or 60,000 people in it. So she set up a simulation, or a resampling study maybe is more appropriate, where she took our data set as a population, and she drew 1,000 samples of n equals 100, 1,000 samples n equals 200, 500, and 1,000. And 1,000 is probably the biggest end you see in the actual primary studies in our field. So she sampled 1,000 times in each of these sample sizes. And now, since she had a population, she knows the optimal cutoff. I mean, if you balance sensitivity, maximize sensitivity, specificity, she knew it was a 10 in this data set. And then she could go into every one of those data sets she drew. So the 1,000 samples the size of 100, and select the optimal cutoff based on the data, right? Which is what people do in these primary studies. So she went in, 1,000 times 100, 1,000 samples with 100 people, 1,000 samples with 200. She identified the optimal cutoff that maximizes jointly sensitivity and specificity. And then she compared those to the true optimal cutoff out there in the population. And what she found is fascinating. I think it illustrates some of the problem in what we do with the primary studies in this area. So if you look at the top left, this is with 100 people in your sample. Only 18.5% of the studies actually identify the 10 as a cutoff, and you'll see, even more importantly, a full 15% were outside the 7 to 13 range. You see, the 85.6% were between 7 and 13, but 14% were even wider. So with small samples, remember 100 people, you probably have 10 cases maybe, and you're using your data to pick a cutoff, so you can move it around to catch your cases, and you're going to get estimates that are really far off. Top right is with 200 people, bottom left, there was a 500. And even with 1,000 people in the sample, now this one you got, 70% were between 9 and 11, given the cutoff 10. But you still had 30% that were outside that range, even with 1,000 people. So, and to do this, then she could also estimate how much they miss or how much they overestimated true accuracy. And if they overestimated, by 5 to 10% on sensitivity, and they lost about 40% on specificity. So that's kind of the pattern that happens here. And this has been replicated. Paresh Bandari did it and put in the journal Clinical Epidemiology with the EPDS also. But what this tells us is not to do primary studies in depression screening, but I think you have to assume when you miss in a specific population of small sample, that it's probably due to sampling imprecision. So you probably do want to rely. You need a lot of data to get accurate estimates here. So we probably do want to rely on meta-analyses and systematic reviews and meta-analyses for making these decisions. Most primary studies don't have enough data to make good decisions in this area. The other area we talked about at the beginning that we wanted to look into were these reference standards. Historically, in every single synthesis I've known, people treat all these reference standards, the semi-structure that involves a real clinician, the lay administered, the very short ones, they put them all together and they treat them as if they're all the same gold quote unquote gold standard or reference outcome. And I've explained a little bit what these were between the semi-structured, the fully structured, and the very brief ones. And again, you could easily get different results depending on the interview. But this was the first study. So Brooke did this. This is the PHQ. So yeah, this is what Brooke did this in early on. But what these lines are, so what we did is we went kind of backwards here, and we controlled for their actual score level on these questionnaires. We thought everyone's getting the same questionnaire. We also adjusted for some of the variables we have, again, sex or gender, age, health conditions are the main ones we have. I think we have, we don't do country because there's too few countries, but we have at the development level using a World Bank index. But the dark line is a semi-structured, and the larger dotted lines are the fully structured. And you'll remember that we said fully structured were more reliable, less valid, right? So they're going to probably, we found that this overestimates at low levels, underestimates at high levels, right? It moves closer to the, maybe, and this is some on both sides of that. And this mini, we find that tended to be kind of above the semi-structure all over the place across the spectrum. And we did that for all of our different measures. And then Yin Wu did a really nice study where she meta-analyzed our meta-analyses and looked at these measures. And if you see here, here on the left, this compares, these are the two main ones that are used, but this is comparing the CD, which is a fully structured interview, to the SCID, which is the main semi-structured interview, which uses a clinician. And the black line, these are all the, sorry. I can't control my phone these days. I thought I was talking to it somehow. I don't know how to, anyway. So the black line is the main meta-analysis result, but you'll see, in the x-axis are standardized scores, so standardized measure scores in the PHQ or the EPDS. And it's a very rough analysis, but it does what you might kind of expect. Maybe something that's, the CD is more reliable, less valid. Overestimates cases. It doesn't rule out cases well enough at lower levels, and it under-identifies people at higher levels. So this has been, and it's quite fairly substantial amounts here. The mini here on the right is a very, very short interview, and it just kind of, this is a little bit messier depending on data sets, but overall it tends to overestimate. And this has been a challenge that we have. So we split up our accuracy results by kinds of measures, because we don't think you put them together. So we really focus on the ones that get the semi-structured interview. And we've been working for several years on what to do with this. We'd love to put these all together, to be able to combine them. But the problem we have is that every single participant gets one screening test and one reference standard. We don't have people get multiple reference standards. So we haven't figured out a way to calibrate this. We've tried about 3 different ways. None of them work very well. So if anyone has some ideas, we'll set it. We'll set up a medal and name it after you or something like that. But we'd love to hear from you because it's a tough problem we haven't. We'd love to put our data together. And this just shows that from our PHQ one that actually the accuracy, both sensitivity and specificity, do better against a semi-structured interview, which you might expect, right? Um, so one thing that Ian mentioned at the beginning is we do a little bit of meta research, and this isn't very complex, but these are some problems we've identified out there in the field that I think are hampering our ability to do good mental health research that we can use our data set to address. But one of the things that happens in mental health research all the time, and this is just propagated, people use these questionnaires and they use these thresholds. And now again, remember these thresholds that we have were set up by somebody, usually set up in fairly small data sets to balance sensitivity and specificity or maximize them jointly, right? So you get a PHQ as a score of 10. The EPDS, people might use a 12 or 13. On the HADS, they use an 8. So these were set up, people use these, and then it's been transformed that people run out and do epidemiological studies, and they say, well, this is the prevalence. And okay, well, it's clearly not a prevalence. There's absolutely no reason to think that that threshold would give you how many people actually meet case disorders. In fact, if you think about screening, the idea of screening is you cast a net out and bring in more people than you think have the condition. And so you have to sort through interviews in this case, but in all cases, more intensive processes. So then some people say, well, okay, well, we can't say it's the disorder. We'll call it, they have symptoms of the depression, if they go above this threshold. But again, I don't think we've ever found a shred of evidence that that's the threshold where symptoms become worse. If you have a score of 8 versus score of 7, on average, your symptoms are worse. Same thing with 9 versus 8 or 10 versus 9. There's absolutely no reason this becomes any kind of meaningful threshold. So Brooke went back early on and looked at 81 depression prevalence estimates from 69 meta-analyses, how they got them. And she found that only 10% were based on diagnostic interviews, whereas 90% were on screening tools or some combination. And that, of course, as you'd expect, the lowest prevalence was based on the interviews. The highest, the 31%, based on a screening tool, and it's a combination in between. So this really plagues. I mean, this is one of the points too, where kind of sometimes I think it begs credibility. We go out and we publish. You'll see results, and COVID, these things were coming out. Cross-sectionally, people we found you'd see papers where people would meta-analyze or systematic review, and estimates of prevalence would range from 10 to 85%. You quite literally see these things. There are another slides like this. And it's clear that 85% or 70% or 40% don't have a mental disorder. So this has been a real problem that plagues, again, sorting out who actually has a condition that we can do much about or is probably impeding function meaningfully. So this was a very simple study. And so there's some complexity to the analysis given the bivariate models that look at sensitivity and specificity jointly. But so Brooke did this, and we've done this again in a couple of other measures. But she did something simple. She compared prevalence based on PHQ-9 is greater than 10, greater than or equal to 10, and prevalence in the same people based on having a SCID diagnosis. And then looked at whether you could pick an alternative. If that doesn't work, can we pick an alternative cutoff that we can use to estimate the prevalence? And she had about 9,000 participants at the time. Found that the PHQ prevalence was about 25%. The SCID prevalence is about 12%, so it more than doubles it. She also found that if you slide it up to a 14 for the pooled estimate across all these studies, you can pretty closely estimate the prevalence. So then you brought down the PHQ prevalence to within 0.5% of what we got on the SCID. But the problem is that there's so much heterogeneity. Again, think about it. If you want to have an alternative cutoff to do this, you've got to apply it in your primary study. It was too much heterogeneity to realistically do that. The difference in individual studies was from -19 to +30, and our prediction interval was from about -14 to 15%. I think people know that, most of you know, the prediction interval is basically how wide of a range would you expect to find the results from any given study in this kind of pool of studies that was going to reflect the size of the studies as well as the heterogeneity across these studies. And we found something similar for the EPDS and the HADS also. And just in short, I mean, so we shouldn't be using these questionnaires to look at prevalence. And I think that's been shown fairly clearly these studies. But you can't also apply interviews to thousands of people either. So, but there is a way to do it. And this is if anyone's interested in doing that, if you can actually simply do weighting where you interview positive screens or some proportion of them and interview a much smaller proportion of negative screens. And we've shown that you can actually cut down your resources really dramatically by doing that and still be pretty accurate. That's probably something like that's probably what we ought to be doing if we want to actually understand prevalence. And then finally, just to close out before we have questions and comments, the last thing so all of this I do to work together with Andrea Benedetti. She's a biostatistician at McGill. So she and I have developed this with the team. And so one thing that Andrea is working on is statistical approaches for IPDMA. And for instance, right now she's working on a network meta-analysis approach for tests, which isn't out there and gets complex. If people know about network meta-analysis, it's nodes of treatments where you have, in every trial you have either one kind of treatment or another one, and you have different comparisons. You can link those to the outcomes. It gets a lot more complex when you have different screening tools, each with many screen cutoffs and so forth. So they're working on doing that. That's only recently done for aggregate data meta-analysis, and so we're looking at that for IPD. Another thing she did is, can we use modeling to fix the problem of the selective cutoff reporting, right? When people only report some cutoffs, not others. This was a nice study Andrea did. So just to point out, we can use this stuff for this kind of work too. Gertrude Ruckert from Germany was working at Steinhauser. They had a model for modeling when cutoffs are missing. Haley Jones from the UK did it. So we sent them all a data set of published data. We took our IPD and figured out which cutoffs were published. We gave them a published data set. We all did this independently. And we did the IPDMA using this. The BRIM is the bivariate random effects model, is the standard model for this. And you've seen this. This is how the ROC curve doesn't work in this scenario. And I don't know if this is good or disappointing, but the models worked. The models overall for accuracy worked pretty well. They actually did quite well. They replicated what we got using the individual participant data. So that's a good sign. So if you want overall estimates, actually, there's some models out there for tests that you can use to get the overall estimates. And of course, the advantages of using their modeling. If the disadvantage of ours is that I've talked about it, mentioned a number of times, is the labor intensity and cost. This is super efficient. You're back to an aggregate model. You can use what people publish, and you get a pretty good result. The downside is it's less precise. You have in some cases substantially less data, so you have a little, some less precision. You have to make some more statistical assumptions about the data and their distributions. And then probably the main thing is you can't actually look at subgroups that way. So you're still limited to what's reported in the studies. But that's another option that Andrea and two other statisticians put together and worked on this. Showed it's a nice outcome that kind of actually shows pretty well that the models they were developing work really nicely for some aspects of this. And with that's I just want to share a little bit what we're doing and how you can use these kind of frameworks, and just thank our steering committee, our team, former team members, and many of them, and led of course by Cheryl, who was managed this project for a good number of years, and all the contributors for this. So with that, I'm happy to discuss and take questions and comments.
Great. Thank you, Dr. Thombs, for that overview of this impressive body of work that you and your team have led over the years. So folks, if you have questions, feel free to type them in the chat or raise a hand and I'll call on you. The one question, maybe while others are thinking, one of my questions was sort of related to the stuff you ended with there, Brett. The selective reporting based on cutoffs.
Yeah.
Do we know from your work, and I'm sorry if you conveyed this and I missed it, or others' work, as to the drivers of that selective reporting? Is it based on directionality of results? So can, and as a follow-up question to that is, can sort of the thinking of publication bias sort of inform and the approaches that have been used to address or to mitigate publication bias in analyses be used to inform the filling in on those not reported data?
Yeah, so a couple of things here. The first one is, why is this happening? I think that it's just because people don't fully understand, and a lot of the time, it's fairly easy to do a test accuracy study in a primary sample. You need a questionnaire and you need someone who can administer an interview. So these get done a lot. Um, but I think the idea is that people overestimate. They don't understand the idea of how inaccurate they can be if they've taken their data set and estimated. So then they report. I think they just innocently report a set of cutoffs around the one they found to be best. I mean, so ideally, it's actually pretty. Like anything else, if we get people to report according to guidelines, they could do it. But if they just put an appendix, it's a simple 2x2 table, right? It's a true, cases that are positive, cases that are negative, non-cases that are positive and negative. If that 2x2 table, if they put that very easily for all the cutoffs, it's just you could get around that problem, right? But I don't think it's the same. Like the thing about this is that it may be a little bit like when you think about a trial, selective reporting means you hide outcomes because you don't want to show, you've measured 8 and you only show 3 because the other 5 don't make your intervention look as good. And we want to publish in the best journal. We want to show that we're, novel and exciting and changing practice, etc. Maybe it's a combination, but I don't know, because these tests, if you're sliding it up and down, you can, you're calibrating questionnaire responses to interview response. They're all going to calibrate pretty highly. It's no matter where you put the line, so they can all make them work. So which comes to your second part with publication bias. Publication, if we're talking about the same term, it means like the studies disappear, basically, right?
Yeah, I think I meant reporting by outcome reporting bias.
Yeah. Because I think that people are able to publish mostly. They just report that, sometimes excitedly, that in this kind of cancer patients, you need a cutoff of 6 or whatever. So,
okay, thank you for that. Let me see if there are any other questions or comments from folks. Feel free to unmute yourself if you can't find your raise hand option. Okay, I'm not seeing any come up. So, Brett, let's go ahead and thank you for this talk and for spending an hour with us today. That was, as I said earlier, that was a really comprehensive overview of some of the challenges and some of the advantages of doing an IPD analysis to address the questions that you've asked. So thank you for this, and enjoy the rest of your day. Thanks everyone for joining, and we'll have another seminar next month. Thank you.
Yeah. Wendy, by the way, I see your note down there. Are you still here? I of course remember. I just actually saw your name. I saw your name here a minute ago.
I came off mute on video just so I could say hi. Yeah, great to see you.
Good to see you. When